I think Dr. Rupal, Dr. Gaurav, and Dr. Rishi will be joining in a bit later. We'll start off with the first debate. I think the two speakers are here. So the first debate is on 465 micron cornea with normal topography, tomography, and biomechanics with a refractive error of -3 diopter sphere. Speaking for surface ablation, it's Dr. Rajat Jain, and speaking for ICL, it'll be Dr. Ikeda Lal. Let's start with surface ablation, and we'll have both talks before we take the discussion.
Good morning, everybody, and thanks, Rishad, for inviting me for this session. So I'll be speaking for surface ablation in a patient who has a -3 diopter refractive error, pachymetry of 465 microns. Everything else is normal. There's normal topo, normal tomography, and biomechanics. So the first question which all of us are worried is, in a thin cornea, can we do PRK legally? I think the slides are not moving there. The slides are not moving there. The slides are not moving on the screen, yeah. It is moving in my computer. Yes. So the first question what we are all concerned is, can we do legally a PRK in a thin cornea? So this is the US FDA guidelines which tell us about the summary of the safety and efficacy of PRK and other refractive surgeries. What it tells us is that there is no mention of minimum PACI for any PRK or LASIK. What it only states is that in any case of a refractive surgery, what you leave behind, the residual stromal bed, should be more than 250 microns. And as of now, till my knowledge, I could not find any separate set Indian guidelines. Probably it is time we put some Indian guidelines. So this question is it allowed legally? So yes, if the postoperative stromal bed is more than 250 microns, you can do a PRK in a thin cornea. Second question is, why PRK? So again, there's a paper which tells us about the PTA, although this paper is applicable to LASIK, but if somehow we apply these guidelines to PRK patients, PTA of more than 40% had a highest risk of highest odds ratio of post-LASIK ectasia. In our patient, -3 diopters, if we do direct calculations, the PTA comes out to be only about 8%. So another paper which tells us about the ectasia in refractive surgery review tells us that the PRK ectasia is only 0.02% in about 1 lakh eyes of PRK. It also tells us that PTA was significantly low in PRK patients as compared to LASIK. We obviously believe that because there is no flap in PRK. And the PTA in PRK patients was 24 microns plus or minus 6%, 24% plus or minus 6%. So in our patient, the PTA is only about 8%. So it's very safe to do a PRK in this kind of a cornea. Age. So age is not specified in the case given to us, but a young age is obviously a significant risk factor in the development of ectasia. And in this Nadelman's paper, it tells us that the scoring of risk is higher if the patient is younger and lower if the patient is older. So if age is also given in this topic which is given to us, it will make it more clear. Then we come to phakic IOLs or ICLs. So are they legally allowed? Yes. Up to from -3 diopters to 20 diopters, they are legally allowed. It is efficacious. Yes, there are more than 100 papers which have told us it's efficacious. The complications usually are surgeon related and they are mostly cataracts. But the question is, if you can do safely perform an extraocular surgery, then why do you perform an intraocular surgery? You can perform both eyes together, so why do you subject the patients to two operative settings? And obviously, you're doing it at 1/4 the cost of a phakic IOL. So considering all this, I would strongly believe that PRK in thin corneas is a way forward, depending upon how much RSB you're leaving. In our case, the RSB is 381 microns, so it's very safe. So I would hence state that I approve that we can do a PRK in a thin cornea. Thank you.
Thank you, Dr. Rajat. I'd like you to just wait up here. Yeah. We'll get Dr. Ikeda's viewpoint and then we'll take the questions. Sure. Rupal ma'am, please come on stage. Okay.
Dr. Ikeda.
Doctor?
Ikeda, yeah, second doc. ये हटा लो प्रीव्यू हटा दीजिए नॉर्मल जस्ट नॉर्मल
ओके आपको स्लाइड चाहिए
नहीं इट्स ओके A very good morning, and thank you, Rishad, for inviting me to this session. And so let's see why I think ICL should be the procedure of choice for a case like this with a 465 micron cornea. Now, when we talk about ideal refractive procedure, what are we really looking at? We are looking at that the uncorrected visual acuity should be equal to or better than preoperative best corrected visual acuity, should have a good efficacy as well as a safety index, should provide patient with a good quality of vision with a quick visual recovery, safe, minimal complications, and least chances of complications like regression and ectasia specifically. When you consider all of these factors, phakic IOL is the only procedure that comes to mind which fulfills all of these criteria. Now, let's look at a few results here. So if we look at results of ICL with central port, this is the V4C model which they had published data with 7-year data. So here the safety index remained at 1.05 at 7-year follow-up, and there was no significant increase in IOP or endothelial cell loss. There was no anterior subcapsular cataract at a 7-year follow-up period, which is reasonably fairly long. And we can see that there are no patients who lost more than one line of vision, and most of the patients had gained visual acuity. If we specifically look at ICL for low myopia, so this is one of the studies published again, and most of the studies quote that 85 to 96% of these eyes are within 0.5 diopters. And there is an improvement in visual acuity. There can be a gain even in low myopia. Definitely the quality of vision is good due to lack of high order aberrations that we might be inducing with a surface ablation. Another study which looked at very low myopes, here we can see that they implanted ICL in less than minus 3.5 diopters, and at a 1-year follow-up, both the efficacy and security index was maintained. So this tells us that ICL has very good results even when we are looking at low myopic patients. Now compare this with the studies that we have on PRK with a long-term follow-up in low myopia. So this is a 10-year follow-up of PRK, and here 42% of the eyes underwent retreatments due to regression, overcorrection, or both. So this is very, very significant. Most papers scored 25% approximately, but that might be due to lesser follow-up than this study. And when we talk about post-PRK ectasia, yes, although rare, post-PRK ectasia is not very common, but can still happen, especially when we are looking at a 465 micron cornea. We have to draw the line somewhere. We have to have some cutoff or a criteria for which corneal thickness we are going to do a PRK. So this is one of the case reports that was published in where they did a PRK for only 1.5 diopters and the patient had ectasia, although on reviewing the topography, they did find that there were some abnormalities and it was a form thrust keratoconus. So still there is a risk, especially when we have a thin cornea. And there is always an issue of post-PRK haze, although it is higher in high myopes, but it can be linked to fibrosis-associated genes, which can happen in low myopia as well. So these patients can also develop post-PRK haze. So to summarize, if we look at the quality of vision, it is better in ICL. The risk of ectasia, regression, haze, all of these issues are not there with ICL. The risk of dry eye is also minimal. And last but not the least, most importantly, ICL is a reversible procedure. So to conclude, therefore, ICL would be my choice. Thank you.
Thank you, Dr. Ikeda. So I'd like to just throw it open to the panel first. Professor Tityal, sir, what would your take be, and would there be any role of things like biomechanics or epithelial mapping in taking this decision? Would that help? Or
I think first of all, I think we understand this patient wants refractive surgery, some sort of refractive surgery. I think that is the most important part for a surgeon to understand. The patient is adamant to undergo refractive surgery, then your choices will come up. And I understand it is the acceptance of a surgeon, he or herself, to do any procedure, because you have wide range of procedure which can be done for each amount of refractive error. And if I am convinced I am good in PRK, so you will be towards the PRK. If I am convinced I am good in ICL in terms of my results and long-term follow, I might go for ICL. So first of all, it is the mindset of a surgeon to convince the patient. That will only happen if I accept this. So as far as I'm concerned, -3 with 465 you have to have some, your own guidelines, because there's no legal guidelines for many procedure in Indian scenario. So you can always be, challenged in the court. FDA guidelines may not be applicable in the legal area also. So normally cutoff is, to 470 microns. And this is little plus minus 470 microns, despite having your, topography is normal. But age is also criteria, which Rajat mentioned, is not mentioned there. But if we do other assessments, do a biomechanics, or do a analysis of other areas, as you talked about, epithelial mapping or a stromal mapping in these cases. And if I'm seeing this patient, maybe patient around between 18 to 22 years of age, I might wait for another 6 months to 1 year for this patient. Assess if things are all right, then might be take the decision. But if patient is above 25 years, wants a surgery, stable these things, my choice might be towards the ICL for this patient, because I'm not for PRK for any patient. My percentage of PRK is less than 1% in last 25 years. So I might bend towards the ICL, especially is looking into the new generation ICLs and long results. My results in ICL is I started in 2006. So we yet to have a serious complication in these cases, despite those generation ICLs also. And the results which Ikita talked about is 7-year results. Results can say 7 years too less for a younger patient. But that is acceptable, I think. If look into my results for last, almost more than 25 years, it seems to be quite good.
Dr. Rohit, any role of extra procedures in this? What would you think in a case like this? What would be your takes?
I think both of them presented and defended very well. But what I would like to agree on with Dr. Rajat's case, one of our fellows presented a free paper yesterday. We are writing it up. We have assumed that corneal thickness of a certain kind is normal abnormal. So we had this 3 years work on looking at the collagen imaging, and we did a PR case. It was with ethics committee approval and all that. So when you looked at the collagen imaging, what we realized is, once where you have a normal biomechanics, when you say normal biomechanics, it's not the CBI, TBI, it's the SPA1 and SSI.
The stiffness parameter.
When you look at the stiffness parameters, and if the stiffness parameters are higher, like for example, your SPA1 is close to around 110, they correlated very well with the very healthy collagen. In fact, they were better than the collagen corneas of 540 corneas. So if you use a little more extra criteria into your assessment, and there are corneas which are thinner and your stiffness parameters are 70 or 80, so that means these are definitely a weaker collagen. So if you use that as your criteria, then I would agree with Rajat that PRK is also an option. But that is something, as Sir said, we don't have anything in the literature to help us with. Even if you're doing a procedures, I take a special consent form which explains that the cornea thickness is thinner, and I have been explained that this is an option, and explained that I have been given an option of ICL. So your regular consent forms may not hold good. So you take a consent form, whether it holds in court of law, we don't know, but at least you kept the patients informed. And PRK extra has really no value. We have realized that it does the same as doing just a good PRK.
And yeah, Dr. Rajat. Yes, ma'am.
So add a little, so there's nothing really much to add. Only thing that I would look at would be what the patient is aiming for. So is he getting it done for some occupational purpose, or is he into contact sports, or is a boxer? Because my decision would also depend on that for the choice of procedure that I would do. Rest, I think everything has been discussed. So
For boxer, you'll go for a PRK?
For a PRK. If somebody doesn't want any sign of anything being done, then also I would go for PRK.
Correct.
That's a valid point, ma'am.
I had one, young lady, around 25, 26, housewife, put an ICL. I put an ICL both eyes, and I think that night I had to fly for a AO, and she came in the evening with a fight with the husband, and husband slapped her. and I saw that this ICL1 happening outside the anterior chamber with the pupillary capture. Just simple one, this thing. So it is, important factor there,
Yeah, Dr. Rajat, you wanted to say something.
I have a question and a comment. My comment is that the studies which Ikeda showed about regression and all, probably they are studies of 2007 and 8. And now with the use of mitomycin C, all those things have come down. And especially regression in -3 diopter corneas, it's probably very less. So my question to you is that when we were talking about biomechanics, if we do the biomechanics on two machines, one provided by Zeiss and one by the Oculus, are they comparable? Is the biomechanics as of now repeatable in those machines?
Not the Corvus and the ocular response analyzer we are talking about.
Yes.
I mean, they two measures. They are not comparable because they measure differently.
Okay.
One measures the hysteresis, which is the viscoelastic property. The other one is the deformation of the cornea. So you cannot you cannot compare them. But if you use them individually, for example, your corneal resistance factor or the CH factors are lesser. But Oculus, the Corvus gives you a little more in-depth analysis of the corneal strength, like the SPA1 and the SSI indices. So they might help you to make a better decision. So when you say biomechanical normal, we only look at sometimes the CBI part of it, but that's a collection of multiple other parameters. But for a PRK, you should look at what is the deformation strength, and for that SPA1 and this would match. That matched very well with our the collagen imaging study, which we are trying to publish it, which will be the first case where we're showing that thin corneas are not unhealthy.
Okay. Thank you. Yes, sir.
Same patient. You said, as far as the FDA guidelines, you need to have a 250 microns plus residual bed thickness.
Yes, sir.
Suppose we go for a 80 or 90 micron flap. Why not to do LASIK for this patient where you are, all chances of haze will go off and quality of vision may be better?
So, sir, speaking strictly by literature, the PTA would be very, very high in that case then, because now we are adding 80 microns of flap thickness also. So PTA would go around 27-28%.
That's less than 40%.
But still,
It's still in a manageable range.
so but then the question comes to biomechanical strength. So I'm not very sure about what literature would say, but before presenting this debate, I would also not touch a 470 cornea for a PRK.
I think this
Now I
issue is, has to be, some sort of a guideline has to
Yes,
be.
sir.
We had to sit down, maybe, one of the associations and get, government's some sort of a tag in this refractive surgery.
So you are the best
So
person
we
to do
can
it.
make a guideline. What should be the, some sort of normative guideline for all refractive procedures.
So it will help all of us medical
Yeah.
degree also.
So maybe we'll start this.
The C1, the one you are having. The guidelines, the Indian Refractive Society and Cornea, which you are.
But no, we need to have some, stamping from the agencies, government agency in that.
Then it can be that if you have not followed that guideline, then you can be questioned in the court, and not everybody's experience is the same. So, for example, I would go for a PRK in a 465 microns, provided I find that that cornea doesn't look suspicious. So, but if the guideline says not less than 470, then I'm in a soup. So, we have to be very careful when we are laying down guidelines also, because
think they
then
have
it
to be-
becomes mandatory for other people to follow who have a different experience.
So at this point,
And not all thin corneas are weak corneas. You can simulate them to modern day women. They look fragile, but they are pretty strong. So please don't go by appearances. Appearances are deceptive.
but most important thing is taking a special consent is important.
Yes.
Yeah, that we can mention, I think for to help the, larger group of people, sort of a lot of medical legal aspects are attached to refractive procedures. And those guidelines will be helpful for most people
Yes.
to, safeguard them, whenever you have a legal things.
Thank you. I think we'll move on to the next debate. That's on low myopia, small white to white, and yellow posterior elevation on bad D. I think this is another thing which probably there are no guidelines on, and everyone gets a bit confused. So talking on Kalex procedures, it's going to be Dr. Apurva Agarwal, and talking on ICL, it'll be Dr. Bhupesh Singh. So Apurva to present first.
Good morning, everyone. Thank you, sir, for allowing me to present here. I'm debating in the favor of lenticle extraction.
So the case scenario is patient with low myopia for refractive surgery, low horizontal wide to wide, and yellow zone on Bellin-Ambrosio display. Why we are debating this? Because none of us want post-refractive surgery ectasia. When can a post-LASIK ectasia occur is when we operate on a patient in which a cornea was already destined to manifest ectasia, or when we have a relatively normal cornea which we weaken below a safe threshold, which is associated with a high percentage of tissue altered. So we all know that Bellin-Ambrosio display map is based on enhanced best fit sphere. So this picture shows a normal Bellin-Ambrosio display, and this picture shows the red mark, which means the patient has keratoconus or ectasia. So in this case specifically, when we look at the quad map, the axial sagittal curvature map looks normal. There is no inferior superior asymmetry. Elevation at the front and the back is also normal, and thickness is around 620 microns, which is normal. But when we looked at the Bellin-Ambrosio display of this patient, it shows the red and the yellow zone, which shows ectasia basically. But when we looked at the horizontal wide to wide of this patient, it is 10.8. So basically, when we have a cornea with less horizontal wide to wide, cornea tend to accommodate more thickness in the less area, which mimics the elevation on the bad display. Now, there are various papers which is being published on the false positive Bellin-Ambrosio and ectasia screening in small wide to wide diameters. So we should always correlate with the quad map. When we are planning for lenticular extraction in low myopia, criteria is mostly similar to LASIK. Of course, there will be a lower residual bad thickness, but in low myopia, adequate thickness is expected. The only challenge is the thin lenticule. When we look into the risk versus benefit, there are various papers which has been published after ICL for elevated intraocular pressure and the retinal complications. Take-home points, bad map should not be interpreted in isolation. We should always correlate with the quad map features. Of course, lenticular extraction is an extraocular surgery, so always related to the lower level of risk. Phakic IOs can be considered, but would be better for moderate to high myopia. Thank you.
Thank you. Next, I'd invite Dr. Bhupesh for his counter on why he would do an ICL in the same scenario.
Normal. So good morning, everyone. Thank you, Rishad, for including me in this wonderful session. And I'll be talking in favor of ICL in this scenario. So we have started discussing the scenario after this paper, which talks about yellow posterior elevation with the smaller wide to wide diameter. But the same paper also says that corneal diameter influences corneal curvature and pachymetry. It also influences bad display, and a small diameter is associated with a steep cornea and can give a false impression of corneal ectasia. Excuse me.
The screen is not showing. Can you just... Yeah, it's okay.
And it has also shown that corneal diameter has no role as a single parameter when it comes to risk assessment for corneal refractive surgery or diagnosis of KC. So we have to look the scan in totality, and we have to consider all other parameters. So if we see this scan, which is published in this paper only, with a wide to wide of 10.8, so if you see DB, which is showing in the red, but we have to look at DT also. So in these cases, DT is always very low. So if DT is low with good pachy and a small wide to wide, you may consider going for refractive surgery or laser refractive surgery, and if not, go for the ICL. As there is an exception to every rule, we have to look all the parameters in the pentacam, like age. If the patient is very young, 18 years or 19 years, we should not be very overconfident going for refractive surgery. Go for the ICL. Corneal thickness again. So yellow posterior elevation with the borderline corners like 500, 490, 510, better to go for ICL. Again, the very steep corneas like 47 or 48, go for ICL. And the other D values, what the other D values are saying, except DP. So there are papers which talk about ectasia and refractive surgery with low myopia, like in ectasia with SMILE, ectasia with LASIK and all. So if you compare with KLX versus ICL in this scenario, the KLX poses some risk of effect on corneal biomechanics after the surgery, dryness, and Quality of vision is then also an issue with the refractive surgery in some cases. But with ICL, we can avoid all these complications. So to avoid so many maybes, ICL would be my choice in this scenario. Thank you so much.
Thank you, Dr. Bhupesh, and thank you, Dr. Apurva. So I think this is a point which is always a little controversial. When you see that yellow or slight red area on the Bellin-Ambrosio display, you kind of know everything on the anterior. The float is fine. When you do the FOMAP refractive, it looks okay, but this flags yellow. And that's when you're put in a quandary. It's because Pentacam inherently, the best fit sphere is about 8 mm, and it's taking more flatter peripheral points in a smaller white to white, and therefore that's why it flags this. So I'd like to throw it open. How do you take a decision in a case like this? And again, I think guidelines. What would we look at in this? Dr. Rohit, sir.
I think she brought it out very well that the Pentacam has many fallacies. Some are very good fallacies which needs to be rectified over time. One of the major fallacies is most of their indices, the best fit sphere measurement is based on an assumption that every cornea is above 11.8 to 12 millimeter. That's how you're looking at a Caucasian eyes or the South American eyes, what they started with. But over time, when you started looking at a new set of, now that's why all indices of Pentacam now is going to have, the Chinese have their own indices. They're coming out with an Indian or Asian indices. So what happens is, so all these years, assuming that if you're fitting a certain amount of volume in a certain amount of space, and your corneal thickness is thicker, then your indices will obviously look bad. It will look like everybody has a posterior elevation. So, but there are cases where the corneal thickness is very high and there is a posterior elevation. For that, you need to be very careful to look at your endothelial cells, because even a small endothelial hydration changes will shift the optics.
I think another thing is to look at the dy and the dt parameters on the BAD-D display, because generally the dt is not correspondingly changed if the cornea is normal. The thickness would not be abnormal. The thickness would be fairly normal in these eyes. And the displacement of the y point would also not be abnormal. If that's abnormal with an abnormal BAD-D, you have a higher likelihood of looking at something like ectasia. Your take, ma'am, and sir, on the...
So if there is no emergency in doing it, I would probably wait and repeat after a period of 6 months to 1 year, so that at least you'll know if it's progressing or if there are any changes occurring both in the posterior part as well as the thickness.
Any role of, again, epithelial mapping in this? Dr. Gaurav, what would you do if you have a yellow elevation point on the BAD-D? The debate is basically on yellow BAD-D with an otherwise okay corneal thickness.
So I obviously missed the previous part, but then what I typically do nowadays is look at the epithelial maps. I also do the anterior and ectasia score as well. You know, sometimes, although it's still not matured enough that, you know, still something that we have to kind of take as an addition rather than as a main decision-making thing. And Rohit probably also uses that. I don't know if he trusts it. But all these things, the epithelium maps, obviously, you know, I've been trusting them for almost 5-6 years. And then, as Dr. Rupal said, I would, you know, if there's a doubt, I would repeat the scans, call the patient back again, you know, it's many times you know, put them on 15 days follow-up with lubricants and stuff, and then see them back. You know, it kind of, sometimes on the next time you do the scans, they just you know, dramatically change. So I think don't jump into surgery.
You keep seeing
on
them
watch
till the scans turn
and
normal.
typically then I'll not motivate these patients to get operated right away. I'll tell them that, you know, we would like to watch you, and as she said, watch for 6 months or a year, and then, you know, take a calculated decision. But if patient is in a rush, then there's a problem always. Then you choose what is the safest procedure at that time. Yeah.
Again, would there be any role of extra in this? Would you do a smile or Kalex extra for that matter in any of these patients? What is the take of the panel?
Extra in a very thick cornea ends up in a very bad haze, and it'll never go. So when you have a haze, if you've done a smile extra and if you have a haze, that means you have to accept that you've done a wrong mistake by choosing a wrong patient, because corneal cross-linking works without haze when your cornea collagen are not healthy, so it makes it stronger. But it's like giving chemotherapy on a healthy cell. So what happens if you give a chemotherapy on a healthy skin, it induces scarring. Exactly same thing happens. So all the haze we get, all the bad thing you get, you had to go back and relook your topographies. It was done on an unnecessary reason.
All right, I think we can move on to the next debate. Are your presentations uploaded, Manpreet? Okay. So next one is ICL sizing. New formulas and OCT-based sizing, is that the way to go? That would be Manpreet's talk, and digital calipers, pentacam, and traditional OCOS sizing by Tushar. So we'll have both talks and then the discussion on the same. Also, I'd request Dr. Pooja to be ready next for her presentation after the debates, after these two debates.
Yeah, so ICL sizing, new formulas and OCT based sizing is the way to go, is what I'm going to defend. No financial disclosures. So we all know why is sizing important, because it's the single most important determinant of the post-operative vault, which we want to be within 250 to 750 microns ideally. So what is conventionally used and recommended by the manufacturers is an online calculation and ordering system, which is based on the white to white and endo ACD, and the white to white is measured by calipers, topographers, or optical biometers. So why is it inadequate? Despite all these, more than 20% of patients do not achieve the ideal vault after surgery. In fact, one of the largest series in which they explanted 2.6% of their fake AIOS observed that low vault was responsible for 50% of cases of explant and high vault for the remaining 50%. So what are the alternatives? White to white has a poor correlation with the actual sulcus to sulcus diameter where your phakic isle is going to rest. Sulcus to sulcus directly measured using UBM is accurate, however, has high inter-observer variance and low repeatability with a lot of potential sources of error. Angle to angle measured using OCT significantly correlates with post-operative vault and ICL size and angle to angle distance, and has a higher reproducibility than the white to white measurements alone. So swept source OCT, which gives you a 3D reconstruction of the anterior segment, is useful for ICL size determination because of the automatic analysis and is more accurate and repeatable. So we have a host of new OCT-based formulas, KS formula, NK, Lasso, Kang, etc., based on swept source OCT using different machines, which take into account different parameters and the newer parameters as well, including the crystalline lens size, the distance between the scleral spurs, angle to angle distance, and the lens thickness as well. So just to highlight a few cases of why where we are is still not enough. This was a case in which both eye 13.2 mm ICL was implanted based on the conventional nomogram. Post-operatively, we had an excessively high vault with appositional angle closure. This was a second case in which a 12.6 mm ICL was implanted and we had a very low vault of 209 microns, which is expected to further decrease with time as well. Another case in which bilateral implantation of toric ICL was done. Post-operative day 1, the ICL rotated 90 degree. We did reorient it and rotate it, but if you see, even after reorienting while hydrating, it was rotating, and after rotation also, it was again misaligned. So it was exchanged with one size larger ICL, and then is when we achieved an adequate vault of 722 micron with a well-oriented ICL at 175 degrees. So in this case, the rotation was occurring despite an adequate vault of 600 plus. It was not a 100-120 vault in which you will expect a toric ICL to rotate. So it was not undersized compared to the conventional nomograms, but the sizing was still not adequate. And on further analysis, we observed that the crystalline lens rise in this case was minus 298, which is much less than normal. Maybe that is why it was equating with an adequate vault when it was in fact smaller. So conventional sizing has issues galore. We often get information from the manufacturer that the lens size you have chosen, maybe there is a disparity between two eyes, or it's the biggest size, it's the smallest size. So we still have not hit the sweet spot. So perfection is not attainable, but if we chase perfection, we can catch excellence. So the conventional sizing needs to go out. Thank you for a patient hearing.
I think Manpreet has been less aggressively attacking this time. I think I was also more afraid Tushar would not have a chance today, but let's let Tushar talk. We're all scared to debate Manpreet. It's all of us run away when we see her name against us. I'm a good friend of yours.
So very good morning. I'll talk about why digital caliper, pentacam, and the traditional sizing is still the best way to go. So starting out with the basis of why I say that. So one day I went to Dr. Manpreet and I said, ma'am, why am I not getting a 500 microns vault in all my cases? She said, have you tried the new NK2 formula? I said, ma'am, I don't have Cassia 2. She said, too bad. Then I bought a Cassia 2 and I said, ma'am, I still don't have a 500 microns vault. She said, have you tried the Lasso full formula? I said, ma'am, but I don't have the MS39. She said, too bad. Then I bought the MS39 and I said, ma'am, I still don't have a 500 microns vault. And she said, have you tried the ciliary body inner diameter using the ultrasound scanner that Dr. Einstein uses? I said, ma'am, I don't have any more money. She said, okay, then you use the white to white and the pentacam. So moving on to the science of it, is more complex always better? There is enough literature that has compared and has actually found that the manufacturer's nomogram with traditional sizing still has the highest concordance with the ideal size. Another study which has compared the manufacturer's calculator versus the OCT-based formulae has found that the OCOS online calculator was the most accurate, and the anterior chamber width and the crystalline lens rise that you get from the OCTs can be used as accessory measurements. They are helpful in modifying that size that you get from the conventional calculator. Also, the OCT-based formulae have been found to overestimate the ICL size, especially in higher ICL sizes. And that's commonly happening because most of these OCT and AI-based models have been developed in Eastern Asian eyes, where you're hardly ever using the larger sizes. That's why they tend to be inaccurate with those sizes. Also, like I mentioned, the main challenge is you cannot use the formulae interchangeably with different machines. So a formula that is meant for MS39 is only for MS39. A formula that is meant for Anterion is only for Anterion. So you need that particular OCT for each formula to be actually be used. And the factors that are the other factors that are really important, like the pupil size, which has actually been found to play a very important role in the final vault, is still not taken into account here. And the other important thing is how the structure of the ciliary body is, and the location where the haptic is actually being placed is very different in different eyes. And that's again not being taken into account here. And angle to angle, anterior chamber width are still surrogate measurements of where the ICL is being placed. And this is how much the digital caliper costs. It's available for 449 rupees on Amazon. So it's inexpensive, but that does not mean that it's inferior. And it's something that is accessible to absolutely everybody. So to summarize, the OCT-based measurements and formulae lack interchangeability between different machines. There is a need for further validation and refinement of these formulae, especially in different ethnicities from where these formulas were trained and developed, and particularly in larger sizes. The digital caliper and the conventional formulae are still highly accurate and inexpensive and accessible to all. Thank you.
Thank you, Tushar. I think this time you were the aggressor in the debate.
I anticipated aggression from her. That's why I prepared accordingly.
So let's throw this open. Are we Are we splitting hairs? There are studies that talk about a lot of the haptics not actually sitting in the location that we intend them to, and that's probably the reason for wrong vaults. So is it formulas? What is your take? I know Dr. Gaurav's done a lot of work on this, so let's get your take.
So I think I know why Manpreet was not aggressive today, because there's no kind of debate. OCT based and UBM based is definitely the way to go, I think. And so she didn't need to be aggressive because she knows that she's got it right. And Tushar is still trying to figure out. So he's defending something which he doesn't want to defend. Anyway. So the thing is that even OCT based and UBM based is not fully there. It's still evolving, and I think we are still kind of understanding. And as he pointed out, between OCTs there is no correlation, between UBMs there is no correlation. So it's not as if they've sorted it out completely. But yes, what we've been working on for the last 2-3 years as well is that using the various lasso formulas. So what we've done is we've kind of figured out a system where we put white to whites from like 5 devices. We put down the lens vault and the crystalline lens rise, the angle to angle measurements, and then using the various formulas, I have a sheet which comes to me with the manufacturer's nomogram calculation, and obviously now some of them are also giving predicted vault. So what we are trying to do is take predicted vault from each of these things. So when I choose an ICL now, I take predicted vault from 4-5 different ways on different sizes. So I have, for selection, when I order the ICL, I have like 5 or 6 different things predicting vault, and I look for consistency across them, that if all of them are predicting, for example, with a 13.2 or a 13 mm, a 500 or a 600 vault, then I'm good. If there is a big difference between them, I will try to start looking at it, that why there is a difference, because some parameter has to be off. So you have to try to make sense of what is going wrong. And also what we've started doing now is we order 2 or 3 sizes for each patient for the same par. And we do intraoperative OCT, and if on table we find that the vault is not right, we'll explant and change it right there. So that's the final frontier. I think that's because you can't go beyond that today. But I think and also there's a lot of excitement about the UBM technologies, because the ICL Guru, of course, from Dan, and then the ICLsizing.com and ICL Guru, both of them are there. ICL Guru is actually taking UBMs. It has 3 or 4 UBMs that it works with, and they are objective measurements. So they are not the run-of-the-mill UBMs. There are ultra-high resolution UBMs, which have also been, like, for example, Sonomed, and so Dan is only working with the Artemis, but this one he's tried to modify on 3-4 different UBMs and get more objective measurements. So there's an artificial intelligence-based software which will capture those images and do the analysis automatically, rather than manually you're trying to, because that was the basic problem with the UBMs, that inter-observer variability. So I think they're trying to get that out of the way.
Any particular importance of crystalline lens rise or anything like that anyone's?
I think both the presentation has given us, so many variables are there to have a predictable vault. And it's very difficult to really have a predictable your outcomes in these patients, what we want. I think there is a need now to have, all these analysis to be compounded, maybe some AI-based system which gives you a more predictable outcome in each patient, so that can be customizable. But given a scenario today, yes, it's good to have OCT-based analysis, which can give you so many parameters, and maybe in difficult cases where your, maybe white to white is shorter or longer, or a AC is too big, or those areas maybe it may be predictable. But given a scenario in the country, most people may not afford all these equipments. If I look into my position today, I may not have these KCA other things with me now. So I may still go with the manual digital marking and just see, and go with the idea with what Gaurav told last. You should have 2-3 sizes available with you, and if you can, intraop measurement can be done, and that may be the best way to go at this point of time. So maybe you should request the company to give you at least 2-3 sizes, and if you have OCT-based microscope with you, then that may be one answer to have a best outcome in these patients, rather than waiting for next day to change the lenses.
Dr. Kumar, I think you had a point as well.
You're not you're dressed up so nicely today.
It's about intraop OCT. The picture that you get on the table, to 1 week to 3 months to 6 months, does it maintain the same vault, or it's different?
Yes.
Yeah, so actually you have to be careful that when you capture the OCT, you know, if your chamber is like flat or something, then obviously it'll be totally wrong. If you have overinflated the chamber, then it'll be different. So you have to just have it right, like a kind of a normal kind of an IOP. Don't make it too tight, and then capture the OCT. It remains almost the same. In fact, you know, there've been now a lot of talk, and I was talking to Dan on this, that intraoperatively you can actually, because where is your ICL sitting, the foot plates, it could be in the sulcus, it could be, you know, on the zonules or the ciliary body, where it is resting. You can actually, with intraoperative OCT, try to have it in the right place. Sometimes if you're getting a very high vault on table, that means your foot plates may not be resting at the right place. You can try to kind of, you know, pull it in and then release it again, and you know, on the other side. So sometimes the vault even on OT table changes when you try to manipulate the ICL. So I think the final resting vault should be checked at before you finish the surgery. That also matters.
I have a question for you. You say you keep different sizes available, but is the company going to be willing to do this for everybody?
So one of the
they
companies
do it
I'm working with is helping me for the study that I'm doing. Yeah.
Yeah, Indian companies will do that, not Star.
Also, for how long do you wait post-operatively for the vault to stabilize?
No, I don't wait. I once I've closed the eye, I mean, and my pressure.
So do you think that the vault changes post-operatively?
Some change is bound to happen, but
so
I
on
also.
the first day, if it is, but then it does change over a period
I don't
of
use
time.
visco.
Your
Okay.
answer, there is some slight change, but we had a study on OCT only, correlating IOCT on table, and then at 1 week and 1 month, and it remained relatively stable, correlated well. There was 10 to 15 micron difference if you have removed all OVD from behind the lens.
That's what I was going to say.
So it does correlate
So
well.
I think she got it absolutely right. I don't use visco at all, so I do hydroimplantation. That's
Yeah.
why my vaults post-operatively don't change
Yeah.
as much. But if you have visco, then you must wash it out completely. Then your vault will not really change too much.
And I have a question for the panel. We are all debating upon having a 150 micron extra vault or a lesser vault. What about the sizes of ICL? We still have only 4. Do we
That's
need
the
to
point.
look into that rather than debating about adjusting the vault 100 microns or so? Are these 4 sizes now outdated and we need to have a more series of lenses? It should be possible with the volume we have now. So why not look into that rather than debate about 100
You'll have
microns
to
of vault?
convince the companies, and with tariffs and all coming
But
these
would
days,
it
I don't know
help
how.
better? Because a lot of times 100, 150 micron vault, we leave it on table. Cataract does not develop.
Answer is, you know, we have a lot of Indian companies making phakic IOLs, and if we work with them, they'll definitely do it, because the ICL per se from Star will have a challenge. But the Indian companies, we have, you know, IPCL, other lenses, they might be, you know, able to do it. And in fact, you know, if you look into their IOLs, they have, you can give you know, the different ranges also. The same thing we can get it done from there. The problem is we have a wide range of this vault. We say 250 to 750 is acceptable.
Anything goes, yes.
And that's why, you know, nobody is working on that to get accurate 500 microns. So that is why people are also not challenging them to manufacture those lenses appropriately. And naturally, these lenses are so near to the nodal point, even 250 or 750 doesn't make a difference in the refractive outcomes. Otherwise, you would have done it. And as you talked about pupil size also, it does make a difference in the vault. But that doesn't change the, you know, your refractive outcome for a distance wise. But if I see my own results with presbyopic phakic IOLs, it makes a huge difference there, because those are diffractive lenses. And little change in a vault makes a huge change in a near and distance outcome in those cases. So if you are looking only for myopic or hyperopic ICL, it may not make a difference. But if you're looking at presbyopic designs, the vault is hugely challenging for all these cases. So that you have to look into.
I think the safety margin is what has been there. It's acceptable. That's why we haven't worked harder on it. Okay, so we'll move on to the next talk by Dr. Rashmi on the battle of the bulge, the melt in stromal augmentation procedures, lessons learned.
Thank you, Rashad, for having me present on this podium. So to begin with, I'm going to be talking about Xenia lenticules. They are porcine collagen implants which are manufactured from porcine stroma. And yes.
नहीं वो आपका स्क्रीन डुप्लीकेट नहीं हो रहा.
आया आ रहा है ना.
आपका वो स्क्रीन अलग दिख रहा है.
अब बीच में तो आ रहा है. आपका ये कनेक्शन लूज तो नहीं है?
नहीं 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 नहीं, वो प्रीव्यू रहता है ना. मैक है. मैक है. वाइट.
ठीक है, अगर प्रेजेंटर व्यू में आ रहा है तो कर दो.
नहीं ना.
Dr. Pooja, is yours ready? I think if that is okay. Okay.
बताना चाहिए ना.
I think yeah, we're
Yeah, I
we're
think
good.
it's working.
We're good.
Sorry. Yeah. So, okay. So I'm going to be presenting on our results with Xenia, further results than what I had presented earlier. So they are essentially porcine collagen implants which are derived from the anterior porcine stroma. And the important thing about these implants are that they are free of cells and their remnants. So essentially the chances of rejection are reduced. The dimensions at the moment are 100 to 150 microns thick with around 7 to 8 millimeters diameter, which can be inserted into a femtosecond assisted pocket. And these lenticules are cross-linked with ultraviolet. In fact, they say it's hyper-cross-linked because they cross-link it multiple times to improve the corneal biomechanical stiffness. So these are the 4 steps that it normally undergoes. First, the porcine collagen corneal collagen lenticule is actually derived, then it undergoes a decellularization process so that it is purified of all the antigenic remnants, and then it undergoes collagen cross-linking. In keratoconus cases which are not suitable for cross-linking or are a little advanced, a femtosecond laser-assisted stromal pocket can be created, and then the lenticule is inserted and then unfolded and centered as per desired. This is an example of one of the patients where the implant can be seen in the anterior stroma. This was done using a femtosecond assister pocket at around 140 microns depth. And these are the slit lamp images in a patient who had a successful implant and did not have any melt. Corneal topography showed that because of the increase in the corneal stiffness and insertion of this stiff lenticule, the anterior corneal curvature did show a significant flattening and change. And these were the results where we started with 9 eyes. We ended up with following up 7 of these eyes for at least a year. And we saw that there was an improvement in the uncorrected and best corrected visual acuity and the keratometric parameters as well. There was an increase in corneal thickness, and the anterior corneal astigmatism significantly differed. But what happened to these two cases which we were not able to follow up is the question that we are seeing here. We were able to publish this recently. These 2 patients underwent explantation for Xenia lenticule at around 3 to 4 months because of a melt which you are seeing here in the photograph. One of the patients had this kind of a melt, and the other one had a similar one which was more towards the periphery of the lenticule, and it was anterior to the lenticule, so we explanted the implants because of that. The histopathology showed that the implant was still acellular and there was no keratocyte immigration or any corneal nerve fiber plexus growing into the lenticule at around 3 to 4 months. A similar experience was presented by this group where they published a case report on early sterile keratolysis. And the hypothesis given was that this could be an immune response to the implant itself, or it could be because of the toxic compounds which are used in decellularization process. On having a discussion with the team that is preparing the Xenia implant, one of the things that came about by the biomedical team was that it could be because of the mechanical stress which is exerted by the implant because of the different biomechanical parameters of the keratoconic cornea and the lenticule. So we decided to go ahead with deeper pockets so that it is in the middle of the cornea, and the stroma above the lenticule and below the lenticule kind of equalizes in terms of the biomechanical stresses. However, we still had implant in 2 of these cases, which had to, because it was deeper, we had to explant them, and patients underwent bulk surgery for these implants. So in this particular paper, we proposed a hypothesis that because the stromal melts were still anterior to the lenticule and we were not seeing much of a reaction posterior to the lenticule, it could be because of the nutrition of the cornea being affected, considering that the lenticule is hypercross-linked, very stiff. It is not allowing any cellular migration into the lenticule even when we are looking at the histopathology. So that is one of the hypotheses that we came about. So just to summarize, these are implants which are successful in improving the visual outcomes because of the change in the astigmatism and improvement in corneal curvature. And they are also helping with volume replacement, could be used as a novel alternative to human corneal tissue in cases with advanced keratoconus. But this technique still needs to be refined further to make the implant more biocompatible and to prevent these adverse events that we were seeing. Thank you.
Thank you, Rashmi. Yeah, Dr. Rajat, you wanted to.
Yeah, hi Rashmi.
Pooja, you can set up.
In the summary of the cases you provided, the implants you're putting out are around 100 to 150 microns thick. But
yes.
But the pachymetry change is only about 30 microns.
Yes, because it compacts over time. That is what we are seeing.
Compacts from 100 to around 30, so it's a lot of compaction. So
yeah, and even the stroma around it is compacting.
So normally when we put normal corneas like Baumann stromal implants, what I used is around 150 microns of tissue, and it usually tends to become 100, 110. So the compaction is only about 30%. In this, the compaction is coming out to be, 100 to 30.
It is more, yes. Yes, that is also another thing that we discussed in this paper, that more than expected, it's not like whatever thickness you are inserting, you are getting a proportional improvement in the corneal thickness in the human cornea, actually.
Would you think that cross-linking that lenticule that you're inserting, is that making it very stiff, and that's why it's a pressure necrosis that is melting the top?
That is what we proposed in the previous paper, so that they can reduce the cross-linking, and then we went in inserted in the deeper pockets, but we still got the melt. So then we are like cross-link it even lesser, and maybe if we make some fenestrations or some kind of a way to provide nutrition to the anterior cornea could be the next step that could be tried.
I think Dr. Sri Ganesh does Philly. I don't know, Dr. Rishi, what is your experience with any of these procedures?
I've only done a few Bowman's layer transplant, and it's been like a mixed result for me. So
I know I didn't find any visual acuity gain, and therefore the patients weren't very, very happy with it. Overall, you'd feel very good seeing the topography, but then outcomes-wise, there was a bit of a gap between that.
Rushad, can I ask one question?
Yeah.
So my question basically is, we are putting stroma, it compacts only by 30%. We are putting stroma, we are decellularizing the stroma and then compacting it and putting it again. It compresses by about, it makes it only 30% of the cornea is left. So what is happening in these two is probably the difference is the collagen cross-linking. So what I believe, and we were discussing, is that we should, CXL on these cases is not required because they don't tend to progress further, so we can stop it.
Okay, next we'll have Dr. Pooja for her talk on post-PRK haze, TGF-beta, and the role of losartan. And I think we've been hearing a lot about this losartan and how it's improving post-PRK and post-cross-linking haze. So we'd like to hear how we can probably incorporate that in our practice as well, if it helps.
Start mirroring. So thank you, Rushad, for including me in this wonderful session, and a good session to have debates and X-files of what is unknown in refractive surgery. So as you rightly mentioned, losartan has been doing quite a lot of talks for the past 1 or 2 years. So being in refractive surgery practice and coming across different case scenarios, especially haze, we are bound to look into it. So this is one patient who was seeking an opinion for refractive surgery. Everything was fairly normal, including her dry eye workup. she had -3 diopters, but the corneal thickness was 475 and 480, so we decided to go ahead with a trans PRK. The surgery was uneventful. Anything above 2 diopters, we do use mitomycin C, which we used for this case also. However, she came back to us after 6 months, and she had this picture in the left eye. Right eye was fine, but she had this picture in the left eye. And on densitometry also, though it looks like a central haze, but on densitometry it was only picking up the haze at 3 and 9 o'clock position in the periphery. So as usual, we started her on steroids and cyclosporin, but though it was a late onset haze, this was not going to work too much. So what did we miss? We went ahead and looked at the patient's pre-op tears, and we looked at the biomarker levels, and you can see here that the IL-17, MMP9 and TNF-alpha is on the higher side, and which preoperatively to begin with, and we've published in the past that if the preoperative levels of TNF-alpha and other inflammatory markers are on the higher side, these patients are more prone to haze formation. Now, though as it's a late onset haze and the steroids and the cyclosporin is not working, we were thinking what to go ahead and do it, and even the tacrolimus didn't work. So looking at the pathways, the TNF-alpha was on the higher side. Now TNF-alpha is something which is responsible for inflammation, and whenever there's higher inflammation, it converts the myofibroblast into fibroblast, which depicts as haze. And there is always an interlink between TNF-alpha and TGF-beta. TNF-alpha is like, it sets your base right, it kicks off the inflammation, and if TGF-beta is also on the higher side, then the chances of haze are on the higher side. So what is TGF-beta? TGF-beta is always needed for wound healing. Anytime the TGF-beta is at the normal level, then it will land up in a normal wound healing. However, if the TGF-beta is on the abnormally high levels, it can lead to abnormal wound healing due to persistent myofibroblast formation. Now here, as you said, TNF-alpha was on the higher side and it was interlinked with TGF-beta. We assume that TGF-beta was also on the higher side. So now, as you mentioned, losartan has been known to suppress the TGF-beta activity, directed scarring of wounded corneal stroma. It basically inhibits the extracellular signal regulated kinase mediated signal transduction. And if you have to use losartan in the eye, you have to have 0.8 milligram per milliliter of prepared solution, because we don't have a commercialized losartan preparation at this point of time. So to simplify, what does losartan do? If there is any, as I mentioned, if there is an excessive myofibroblast formation, it will depict as haze. Losartan basically tries to kill this myofibroblasts which are forming into fibroblasts. So it basically starts cutting down your haze which has already formed, and it then leads to a normal wound healing. So losartan acts on not on preventing haze only, but it acts on cutting down those fibroblasts, which will reduce your haze and scar formation, and the cornea will go back to normal. Now this patient, we started on losartan eye drops 4 times a day. 6 months, it's still an ongoing treatment, because as you may have heard from published reports, losartan does take a longer time to act. So it's already been 6 months and the haze has come down by 50%, but not gone down completely, but patient's vision has come back to 20/20, so that's a good thing. Now losartan doesn't only work on PRK haze. I think this is my colleague's case, Dr. Gairik. It also works on losartan in corneal scar post-infections. And it does take a longer time, but at 1 month and 3 months, you do start seeing these differences and the haze starts coming down. So, and this is one OCT picture. You can see that there is a reduced contraction band towards the area of fibrosis and reduction in scar density. So what the mechanism is that it starts cutting down your myofibroblast and fibroblast to lead to a normal healing. You can actually see in this OCT image. So few of the cases where your primary treatment is not working, trying losartan would be a way forward. However, there is a challenge that it's not commercially available. There's no solution of losartan, so you do have to take the powder form of losartan and then mix it with one of your lubricant drops and prepare it, and then the sterility and all that. So there are a lot of issues, but if one of the companies is interested, then probably they can take it up and it becomes more easier for us, because post-PRK haze is still 3% in everybody's practice. Thank you.
Thank you. That's a very nice thing that we've got. I'm going to just start using it. I think Dr. Swami sir has got it for me. Any
So
questions?
right now we are
Powder form, to be very honest, it's very difficult to get, but you have to talk to one of like a company like Micro or Sun Pharma who are preparing the losartan based tablets. You have to take it from them
and then prepare it. So it's not easy to get powder form also at this point of time. It's quite challenging. So though it has showing promising results, but to prepare only, if I get a patient, I have to tell them to come back after 2 weeks because it takes that much time to prepare. But when you have no resource left, then I think this is working quite well, because at this point of time, steroids or any immunomodulators don't help us. So it's challenging, but I think as if all of us get together, then one of the companies will take it up, and we will have to tell them that, help us.
The problem is it's off-label even abroad. It's not.
Sir, it's mitomycin C. Mitomycin C is also a off-label drug for PRK.
You think it would work even if we prophylactically start?
It has a mechanism. People don't, it's not published in the literature in prophylactic, but as I mentioned that it prevents the myofibroblast to convert to fibroblasts. So it has a prophylactic form also that you can start at 1 month post-surgery and it can help. But we've not used it at this point of time.
And are there any side effects noted?
One of the early side effects or what we see is patients complain of little bit of burning sensation. So I think we have to still choose the right lubricant with which we mix it. We've done it with sodium hyaluronate at this point of time, but patients do complain of little bit of burning sensation. But otherwise, no impact on the ocular surface or dry eye parameters in at least I have the post-PRK patient, it's been 6 months. Only complaint she had was burning sensation, but rest, everything looks fine.
That could be a pH issue.
And this PRK patient, we've done a recorrection already. We've already done a PTK, and she again has a scar formation with that. So it was not like, so after that we were only left with losartan.
I have a quick question. I know he's waiting to talk and time is almost up. In your patient, you got haze only in one eye, whereas the tear levels were...
We did yeah.
So what was the confounding factor? Like why only...
alpha, probably.
But wasn't it kind of elevated in both eyes? Was it in...
the other eye, it was half of the...
I was trying to see that when I missed it.
It was half the range, other eye.
Right.
So
And mitomycin protocol, what are you using for your patient?
every diopter 10 seconds.
10 seconds.
Yeah.
Was the cylinder more in this eye by any chance?
Kind of.
Yeah, so I think that's the
-2. Another eye was plano. I try not to do astigmatic corrections.
So
after
it
this
will
patient.
ablate the periphery, and that is known to cause more haze.
You got it right.
Yeah, so that's
but
probably the
this
reason.
patient, I wouldn't kind of do smile extra, so PRK was the only option for me.
So I think one of the important message to give the audience is when you're doing mitomycin application for these cases, we have a habit to just put in the center.
No, we do it
You
on
have
the
to
side.
specifically make
Yeah.
sure that you cover the site where the ablation has happened, and the sponge has to be wet enough. If it is absorbed all the mitomycin, then it's really not going into the stroma.
Yeah, that's a good point. Thank you.
Okay, so we're going to end the session with this talk on our early experience with Liftigrast. Now we know that dry eye is a multifactorial disease with basically a loss of homeostasis of the tear film instability, hyperosmolarity, and ocular surface inflammation and damage. We do get these severe dry eye patients with aqueous deficiency, and that's divided into the Sjogren's and non-Sjogren's type. The eventual pathogenesis shows an epitheliopathy, sensory neuron activation, goblet cell density reduces, and there's an immune cell infiltration that happens. What we are doing when we are treating with tear substitutes is we are fixing just the tip of the iceberg, so to speak. The options in our armamentarium so far are ocular surface lubricants, anti-inflammatory drugs, punctal plugs, and topical anti-inflammatory agents. Now, artificial tears don't really address the root cause, and corticosteroids are kind of like dropping an atom bomb on this, where you're pretty much causing a lot of other issues like cataract, increase in eye pressure, etc. So we have come up with various different molecules to help counteract these issues, and we have had things like cyclosporin, tacrolimus available to us, and recently Liftigrast has been made available to us in India. Now, how does this act? It's an LFA1 antagonist. It acts extracellularly by blocking the binding of the intracellular adhesion molecule to lymphocyte function-associated antigen 1, and that's how it brings about its anti-inflammatory effect. So there's a strong inhibition of this T cell adhesion to ICAM1 expressing services. It's got a high solubility in aqueous media, so it's formulated as a sodium salt, which allows concentrations of less than 100 milligrams per ml to be isotonic with human tears. It's got a reasonably rapid absorption and a relatively rapid clearance from the systemic circulation with a good safety profile, so it doesn't have much of systemic side effects. So what is the evidence? We've seen these studies, the phase 1, phase 2, phase 3 studies. This was the liftigrast ophthalmic solution 5% study for treatment of dry eye disease. They looked at fluorescein and lissamine staining scores, the OSDI index, the 7-item visual analog scale, and the ocular discomfort. Basically, there was an improvement in corneal fluorescein staining. The limitations of this study were relatively short treatment time. They did not allow any concomitant therapy with artificial tears or cyclosporin. There was selection only of aqueous deficient subjects. No significant difference between the groups in the primary endpoints were noted, and no significant change on the visual related scales were seen. So the phase 3, the second study that was done, was placebo for treatment of dry eye disease. In this, in the OPUS phase 2, they started evaluating the efficacy and safety of liftigrast compared with placebo for treatment of dry eye. So it used adults aged 18 years with use of artificial tears within 30 days, with inferior corneal staining score of 0.5, Schirmer's tear test between without anesthesia between 1 and 10, and an eye dryness score of 40. And what this showed again was that there was a little bit better inferior corneal staining with the liftigrast group. The eye dryness score became a little bit better, as did the ocular discomfort. The limitation were the subjects were actively using artificial tears, again limited treatment duration, and they excluded subjects with known active lid margin disease. Now the third arm of this study, the objective of the OPUS 3 study was to evaluate the efficacy and safety of this compared with placebo in participants with moderate to severe symptomatology instead of the milder symptomatology. Again, it had a relatively short treatment time, limited to patients with at least moderate baseline symptomatology, and those wearing contact lenses, which form a large part of dry eye, were excluded. To summarize, basically liftigrast blocks the LFA and ICAM1 interaction. It's FDA approved treatment for both signs and symptoms of dry eye disease. It's proven to improve eye discomfort, dryness, and visual function, superior to CMC but similar in efficacy to cyclosporin. And the long-term safety profile is good. The other thing that was seen was also on lipid layer thickness. We did not find any kind of a change in this between the two groups. So could these have synergistic effect where they work together? Well, basically cyclosporin works intracellularly, whereas liftigrast works externally. So these could potentially be combined together as treatments for mild and moderate dry eye disease. I'd just like to summarize with our initial few cases. This is what we found when we put these patients on liftigrast. They did, of course, have artificial tear substitutes going on as well. In general, we found a slight improvement in the Schirmer's and TBOT scores and the OSDIs as well. However, there were cases where there was a lot of stinging sensation, so we did have to actually withdraw the liftigrast as well. There was one case like that. So thank you for patient listening, and thank you for being part of the instruction course. I know we ran a little short of time at the end, but I think overall a good discussion. I'd like to thank all my panelists for being here, all the speakers, and a wonderful audience for attending so early in the morning. Thank you.
Good job. I have a small comment on this. So even I've been using liftigrast for a while. And like you said, we also had a few patients who just couldn't tolerate it, and we had to go back to restasis and others. But it's been very good for patients with adult VKC, actually, the severe ones. So those, because they're already uncomfortable in the eye, they tolerate it much better, and it's more effective is what I've seen.
So a couple of patients swear by it and a couple of patients hate it. It's kind of like a mixed bag that you get with cyclosporin as well, I think. Thank you. Can we just have a group photo and then we'll vacate the stage?